hemodynamic deterioration. Thank you.
Thank you, Dr. Satish, for your nice deliberation on broad QRS tachycardia, especially to differentiate between ventricular and supraventricular with emergency. Despite all that, it's really a nightmare. And I think all of us have that scare, whether this is a tachycardia, ventricular tachycardia or SVT with aberrancy. And there are so many causes, and when you have put so many criteria, it's quite difficult to, by heart those criteria. I think my advice is, you keep on seeing the ECGs, probably you'll understand them better. With this, I think everybody is waiting for the lunch. I invite one or two important questions if somebody has. Yeah, there's a mic, please.
Given a setting of ICU, as you were telling, to differentiate a wide QRS tachycardia, supraventricular tachycardia with aberration and VT is okay. Suppose if the patient has a history of antidromic the WPW, wherein that also will give a wide QRS tachycardia. So standing in front of the patient, we have a SVT with aberrancy, we have a VT, then we have this WPW with an antidromic. Then how do we differentiate antidromic from the VT or the other one?
As I told, we can differentiate SVT with aberrance from VT by looking at, first is always go look at the AV dissociation, look for the basal ECGs if it is available.
Yeah, that
then
part
look
is
for fusion capture bits. Then finally apply the morphology criteria. As you rightly told, SVT with aberrancy and VT we can differentiate one morphology criteria.
Yes.
But it's most of the times we will err on differentiating VT from antidromic
Yes.
tachycardias.
Yes.
Especially if it is a posterior septal pathway, antidromic tachycardia can cause concordance pattern in V1 to V6. We can falsely diagnose
As a VT.
Diagnose it as a VT.
Yeah.
So if in those cases, if a baseline ECG is available, baseline ECG is available, look at it. If there is a delta wave with a short PR, it most likely suggestive of WPW syndrome. If baseline ECG is not available, I think diagnosing antidromic tachycardias from VT will be difficult.
But the Brugada has given a criteria for that. I mean, to differentiate VT from antidromic WPW. But those criteria, I mean, what I am trying to tell you is, when you look at those criteria of differentiating supraventricular from aberration from VT and VT from WPW, they look same almost. I mean, if you refer, because I have brought the Xerox if you want. See, they look almost, because they are talking of AV dissociation, QRS widening and concordancy.
An antidromic tachycardia, the AV association will be there.
Yes, I mean, if you look at the Brugada criteria, AV dissociation he has given as the first step. I have the Xerox if you want, I mean, I can show you in the lunch hour. So it's very difficult to, because the treatments are different. So what I am trying to ask, suppose if you give amiodarone, which is helpful for both, is it okay? I mean, I'm just asking you, I don't know.
Yeah, you can, if you are, we can give adenosine.
No, I mean,
you can use amiodarone.
We will not use anything which goes to the vagal nerve.
Yes.
So amiodarone is the best one. I mean, can we use amiodarone as a general rule whenever we have a wide QRS tachycardia, sir?
One thing. See, the thing is, there have been a case reports where they have given a amiodarone in a WPW syndrome with antidromic tachycardia. It has precipitated atrial fibrillation with a rapid conduction. So
amiodarone?
Amiodarone, yeah.
Because
what they say is safest will be a class 1C drug.
Sir, this WPW with antidromic is also vagal dependent. Amiodarone is not a vago blocking.
No. I'm telling you, these are case reports. I'm talking about rarely. You can use amiodarone, but it can result in atrial fibrillation with a rapid conduction over the axillary pathway. Safest will be to use class 1C drugs, which unfortunately
they are not available.
Not available. We have only oral form.
Oral form, flecainide.
Or Cetolol, but I don't know where they are available in this country.
That is what is recommended is procainide or procainamide or a flecainide.
But even if you give, as you rightly told, even if you give amiodarone and you can terminate. Absolutely. But if it precipitate atrial fibrillation, always if human unstable, do cardioversion.
Yes,
best thing would be to
cardioverting.
Yeah. Absolutely.
If once you don't atrial fibrillation with
I agree. Yes.
And we always hesitate to do we underutilize the cardioversion a lot.
Yes, yes, I agree. Yes.
No harm in taking the patient immediately out of the thing. Yeah, precipitate ventricular fibrillation, that will be much more problematic. And other thing is, as you said, antidromic tachycardia is conduction through the ventricle only.
Yes, ma'am.
So there is no way you can differentiate VT from antidromic tachycardia.
Actually, textbooks tell to give amiodarone in antidromic WPW. So
What it says class 1AC and class 3 drugs.
Yeah, if you want to give any medication, patient is stable, probably as you said, amiodarone maybe, but it takes time. That is the other thing. And yeah. I think if there are no further questions,
I think we are between the lunch and.
Thank you, sir. I request Dr. Shashidhar to hand over a certificate to Dr. Satish. And I request Dr. Satish to hand over the certificates to the chairpersons.